This program is brought to you by Emory University.
Good morning, everyone, and welcome to Heart and Vascular Grand Rounds. This morning we have a special treat. David Cohen is with us today. Many of you know David from his extensive work in outcomes, cost effectiveness, and a variety of areas related to interventional cardiology. David went to Harvard Medical School and graduated from probably one of the best classes ever. We were classmates together. And did residency at the Brigham, further training at the BI in cardiology. And most of you know him from his long-term standing at Mid-America and his many contributions in the area of interventional cardiology, and is a major player in many of the trials that we all use to help guide our care every day. He's currently involved in sort of the major trials that are going on right now with TAVR, et cetera. And his topic, I think, is pretty interesting, given his interests, which is he's going to tell us all about technology in the Cath lab, and I think that's going to be a very interesting topic in these times. So, welcome, David. It's great to have you here.
Well, thank you, Bob. It's great to be here. I've been to Emory many times before, but I realized I really haven't been over to the Cath labs at all. It's always been at conferences or those sorts of things, and I was remembering back that the very first time I was here was probably in the late 90s to help Bill Weintraub at the time design part of what became the Courage trial, which was called the SMART trial at the time. So it's really nice to actually get inside the walls here at this point. So thanks for the invitation, and hopefully I'll keep you guys entertained and you'll learn something this morning. So I am going to be talking about technology and how we think about whether they are just expensive or whether they're cost effective. These are my disclosures. I get research support from a number of different device and drug manufacturers. So why are we talking about this whole issue of economics in the Cath lab or in cardiology? And it's really because of some of these things. So this is just a partial list of some of the major advances and devices in particular in cardiovascular disease over the last couple of decades. And you can see things ranging from ICDs and LVADs down to things that I use more commonly like drug-eluting stents and TAVR. And every one of these things is very expensive to purchase if you just buy them off the shelf. But what really makes the economic story challenging is that cardiology is such a, cardiac problems are so ubiquitous that we have these very large numbers. If we were to apply each of these therapies to all of the suitable patients, we would be spending billions and billions of dollars just on the technology alone. And so for this reason, I became interested many years ago in really understanding the value of all of these technologies, because I think we really do need to understand this in order to practice good medicine in the 21st century. So I'm going to just start off with things that I never learned in medical school for sure, or in cardiology fellowship or anything like that. I just want to spend 10 to 15 minutes just setting the groundwork on how we think about health economics, again, in the world of technology assessment. And it always helps. I remember when I was in college, I took one economics course. Many of you probably did, Economics 101. And we learned from this gentleman over here, Adam Smith, one of the kind of early economists around the area of capitalism, that the challenge with economics is really that our resources are limited, no matter where you are and what time you're living. But human beings, being who we are, our wants are unlimited. And nonetheless, somehow we're going to allocate these resources. We're going to make decisions. Even a decision not to make a decision is still a decision. And so this is really the foundational principle on which all of economics occurs. Just to give you an idea that in the last 250 years, things haven't changed very much. So here's economics in the modern era. You can't always get what you want, but if you try real hard, you might get what you need. Same story, just updated a little bit, and this, of course, is by Jagger and Richards, one of whom is our most recent and famous TAVR recipient. So it's the more things change, the more they stay the same. There's a couple of basic principles that I want you to kind of hopefully walk home from this talk thinking about, and this is probably the most important one, which is the difference between cost-effective and cost-saving, because I think at some point health economics gets a bad rap. They say, oh, well, you're just trying to save money. It's just about bean counting, and it's not at all. And the reason for this is how we really think how a health economist thinks, or how, frankly, how anybody who's allocating resources ought to think, is that any technology that comes along is going to have two dimensions. It has an effectiveness dimension, and a new treatment can either be more effective or less effective than whatever else is out there. And it can also be more expensive or less expensive than whatever else is out there. Every once in a while, something comes along that's in this lower right-hand quadrant, more effective, less expensive. That's a no-brainer. We want to do that every time because that saves lives and it puts money back into the healthcare system. Also, every once in a while, something comes along that's over here where it's less effective and it's more expensive. And I'll talk about one of these a little bit later. And those are things we don't want to do at all because, again, they don't help people, they hurt people, and they cost us money. But the challenge for us, so those are the two easy quadrants. The challenge for us in modern medicine is that most things are in these other two quadrants where things are not quite so easy, and in particular in this upper right-hand quadrant where we are gaining some effectiveness, but we're also paying a price for that. And our challenge is to really try to weigh those benefits and the costs against one another. And all of cost-effectiveness research really is in this upper right-hand quadrant, as you will see. And the idea of cost-effectiveness analysis is really just what I've summarized here. It's a technique, an analytic approach, where we are trying to allocate our health investments in order to maximize the aggregate health benefits to society subject to the constraint of a fixed healthcare budget. I have to read that every time because it's such a mouthful, but it's really a very, very simple concept, which is that you have a pot of money to spend on healthcare, and if you use cost effectiveness and you use that to actually allocate your investments, you're going to spend it in the most efficient way possible. You're going to gain the most health for whatever group it is you're trying to decide. And the reason why this has taken off in medicine and why it's popular is partly because you can measure the costs and the health benefits in their natural units. You can measure costs in dollars, euros, or francs, or whatever it is, the currency that you're working in. And you can measure health benefits in a variety of different ways, although there are some standard ways that are a little different than this. But you can look at the number of lives that are saved. You can look at the number of years of life that are gained if therapies extend life. You can look even at things, intermediate outcomes like complications prevented, and again, we'll talk about this in a little bit. And what you do once you've actually measured the costs, measured the health benefits, is you express them in what we call a cost-effectiveness ratio, and that's this little piece of math that's down here, which is just a difference in cost, comparing whatever the new technologies you're evaluating to the standard of care, divided by the difference in effectiveness, and that forms what we call the cost-effectiveness ratio, or an ICER. And it's very important, though, I wrote there in parentheses, this versus best alternative, because you can make things look very, very cost-effective if you compare them to something that isn't this, the current standard of care, or something that isn't cost-effective in and of itself. So it's always very important when we do these analyses to make sure that we're comparing really against what's the next best thing. So what goes into that cost-effectiveness ratio? So it's a pretty simple piece of math, but getting all these little pieces sometimes can be challenging. So the numerator, the costs, well, you first, of course, have to think about the direct costs, what are actually buying the device, the labor, equipment, supplies necessary to employ whatever that clinical strategy is. There are indirect costs, overhead, which everybody who works in a hospital knows far too much about. Very importantly, whenever we think about cost effectiveness, we're thinking about a long-term decision, and so there are induced costs. And induced costs can be positive if there are complications. Again, you do an angioplasty and there's episodes of restenosis that you have to treat. Those are complications that wouldn't have happened without the angioplasty. Those are induced costs. Similarly, on the other side of things, if you have a strategy that saves money, let's say we have a new drug for heart failure that reduces the number of follow-up hospitalizations, well, those induced costs would then be negative. You kind of get that back as a credit. And then there are also things like productivity costs, both for the patient as well as their family. All these things go into that numerator of the cost-effectiveness ratio. What do we typically put in the denominator? What we typically put in the denominator, if you can imagine, this is a treatment, let's call this heart failure with severe mitral regurgitation, and then we have a new treatment like the mitral clip or something, or biventricular pacing, or anything like that that comes along and shifts our survival curve. What goes into the denominator typically is a life expectancy, which is just the area between those two survival curves, and ideally, we want to quality adjust that. We want to take quality of life into account as well. And so that's really what's going into the denominator. Now, what's the idea of quality adjusted life years is something that is both sort of, beautiful and ugly at the same time. But just to give you an idea of what this is, it's something that wouldn't exist if there were not health economics. Nobody would come up with this in their right mind. But if you think about a patient, a quality adjusted life year is really a metric that, that economists have come up with for combining quality and duration of life into a single measure of health effectiveness. And the idea here is, if you think about, let's say, a 55-year-old man walks into your office, and initially he's in very good health, And then he develops severe angina about 3 years later, and he just, kind of stays at home and doesn't tell anybody about it, doesn't complain very much, but he's having a lot of severe angina for 3 years. Finally comes in to see you, gets a coronary angiogram, has bad three-vessel disease, gets a bypass operation. Now his angina is just very mild angina, lives for another 5 years in that state, then unfortunately has a stroke, and a year after the stroke, he's died. Well, this patient has lived for 12 years, but they've been, in different states of health. Some of them have really been in excellent health. Some of them have been in very poor health. And the idea of quality-adjusted life expectancy is really just integrating the area under this curve where we are weighting each year of life by something called utility, which reflects the patient's preference for his health on a scale where 1 is perfect health and 0 is basically death or the worst possible health you can imagine. And if we do that with this simple example, what you can see here is if I add up all the little areas of these different rectangles, I come up with 9.9 quality-adjusted life years. So this patient has lived 12 years, but it's also been 9.9 quality-adjusted life years. And what this means, at least one way of conceptualizing this, is if you offered the patient, the choice between this sort of series of events or 9.9 years in excellent health for that entire period of time, so a shorter period of time, but in excellent health, they would be indifferent to that choice. They wouldn't really be able to make a clear choice between them. And that's really what the whole idea of quality-adjusted life years is getting into. So what do we do? So we've talked about the costs. We've talked about the denominator, the effectiveness. How do we use this information? Well, the ratio is very easy to calculate. So in theory, again, what we would want to do is we would want to calculate a cost-effectiveness ratio for every single way that we could spend our healthcare dollars, and then we would want to rank our programs in order of increasing ratios. You start with the ones that save money and save lives. Those are the no-brainers. Everybody wants to do those. Then you come to the things where you spend just a little bit of money and gain a lot of health, and that's the next place you spend your money. And you basically go up and up and up the list until you're out of money. That's really, and if you could do that, from a practical standpoint, you would have actually allocated all of your healthcare dollars in the most efficient way possible. Practically, you can't do that because you can't evaluate the cost effectiveness of every single thing. So fortunately, we have now some reasonable standards. These are actually ones that were endorsed by the AHA-ACC about 5 years ago for evaluating things in terms of cost effectiveness ratios. And what they established, and these are, again, generally accepted principles around the world, is that a high-value therapy in the United States is something that has a cost effectiveness ratio of $50,000 per quality-adjusted year of life gained or less. An intermediate value therapy is between $50,000 and $150,000, and these thresholds actually come from the per capita GDP. This is about $50,000 is about 1x the GDP, $150,000 is about 3x the GDP, and then anything over $150,000 per quality-adjusted year of life gained is considered low value. So now we have some benchmarks in some areas where we can actually apply this information, and these will come up as I start to show you a couple of examples. A couple of last points that I want to make before I switch gears and start talking about how this actually affects us and how we can use this information in our care and in determining our guidelines and those sorts of things. Cost effectiveness depends on perspective, and I think it's very important for everybody to keep this in mind. And to make this case, I can just sort of show you a very simple example that I made a number of years ago but still works. So think about a 40-year-old man who comes into your hospital with unstable angina. He has a Cath that shows a high-grade lesion in his LAD, undergoes a successful angioplasty and a stent. He spends 1 day in the CCU, 2 days in a step-down unit, goes home on hospital day 4, and then a couple of weeks later, he walks out to his mailbox, and there's a bill out there for $19,000, which is HMO coverage in full. So let's ask a very simple question about this very typical type of scenario. How much did that hospitalization cost? The answer, if you read the title here, is it depends. And it depends on who you ask. So if we ask the patient, well, is HMO covered the whole thing? So for the patient's perspective, it was free, didn't cost him anything. If he asked the HMO or the third-party payer, yes, well, the hospital bill says $19,000 on it, but they have some negotiated rate, maybe it's $12,000 or $10,000, and that's what it costs the HMO or the third-party payer. If you ask the hospital, it cost the resources that went into taking care of the patient. It cost the drug-eluting stent they got. It cost the anticoagulant and the antiplatelet drugs. It cost the nursing time and the meal that they had in the hospital the night after their PCI. All of those things are actually the costs of this episode from the hospital's perspective. And if you ask society what the cost was the cost for the hospital care and then anything else that happens downstream. So if this patient needs to take dual antiplatelet therapy for a year to keep their drug-eluting stent from thrombosing, well, that's a cost from society's perspective. If they have an episode of restenosis 6 months later, that's an additional cost from the societal perspective. So very simple example, very prototypical case. 4 different perspectives, 4 different answers. The important thing is they're all right. Okay, none of these is wrong. They're all correct. And so the key message here is that whenever we're doing cost effectiveness analysis, one of the first things we have to decide is whose perspective are we taking. Now, very typically, what we are taking is a societal perspective because we're trying to figure out how best to allocate society's resources, or potentially a healthcare payer's perspective. But you shouldn't be surprised if you take an analysis done from a societal perspective to your hospital administrator and say, see, David Cohen said this is very cost effective, and he says, not to me it isn't. Because again, they have a very different perspective. They have and you have to understand that when you're using this information. Last point, treatments are not cost effective unless they're effective. And this one is for everybody out there who's going to start a biotech company or something like that in a couple of years. Because in my career, I mean, I've become known for all of this work, and not a month passes without some company or some friend or somebody like that calling me up or emailing me and saying, Dr. Cohen, we heard you're, somebody who does a lot of cost effectiveness work, and we've got this great new device, drug, whatever it is, and we want you to help us, show that it's cost effective. And I say, that's terrific. Where is your evidence? Where's your randomized clinical trial that it works, that it's effective? And they say, oh, well, we're just getting started on that. It's going to take us a few years. And I say, okay, well then come back to me in 5 years when you have a denominator for your cost effectiveness ratio that's something other than 0, and we've got some place to start. Because again, nothing is going to be cost effective. The only way it's going to be cost effective is if it saves money, and none of these companies are ever interested in saving anybody any money, or if it improves health in the denominator. So effectiveness is always the first step along the way. And again, I say that a little bit tongue-in-cheek, but it really is amazing how many people don't really understand this until faced with the actual math. So now I'm going to take you through 2 case studies that have basically occupied the better part of the last 20 years of my life, for better or for worse. And the first one is kind of an example that is not that relevant today, but I think it's a good example because it really shows kind of the power of what we can do and how you can, if you collect the right information over an extended period of time, how you can learn a lot of things about a technology that cost effectiveness feeds into. And we're going to talk about drug-eluting stents, which everybody knows. This is a pig's coronary artery with a regular bare metal stent. Here's a pig's coronary artery on a drug-eluting stent. We know that we have 95% of what we use today in the Cath lab are these drug-eluting stents. And they've definitely improved outcomes for all, for the vast majority of our patients. But they're not cheap. Even today, as the prices have come down, we spend billions and billions of dollars on drug-eluting stents every year in the United States and around the rest of the world. So when these first came out in 2003, we said, we need to understand the value of drug-eluting stents. They're a big technology. They're certainly a major step. And so how do we think about cost effectiveness of drug-eluting stents? So the first question we set out to ask was, do they save money? Because if they save money, well, maybe the work, our work is over. And so in order to understand whether drug-eluting stents saved money, we had to first understand about the economics of the disease that drug-eluting stents treat. And the disease that drug-eluting stents treat, for those of you who are too young to remember bare metal stents, but Spencer remembers all of this stuff like I do, is the disease they treat is Restenosis, which again, fortunately, is a much less common disease. But in order to understand the economics of Restenosis, we had to go back before there ever were drug-eluting stents. And so we did this study back really in the early part of the 2000s, where we took Medicare data from 1998, 1999. That's when we had bare metal stents. They were, being widely adopted. And this is about 12,000 patients who had angioplasty in the Medicare system. We followed for a year through their claims data to ask a couple of simple questions. One was, how often did patients actually come back for repeat procedures? Because surprisingly, at that time, we really didn't know this. We had clinical trials where we did angiographic follow-up and those sorts of things, but we really didn't know what a free-living patient in the United States had for a restenosis rate. And the answer was around 16%, although it's probably a little bit lower than this because some of these were procedures done on other vessels. And in fact, if you estimate based on clinical trials that about 75% of these were actually at the original lesion, the clinical restenosis rate, even before we had drug-eluting stents, wasn't as bad as some people made it out to seem. It was about 12%. So about 12% clinical restenosis. You can see the vast majority of those patients were treated with PCI, but some of them got a bypass operation. So that was question number 1 that we wanted to know. How often does this actually happen? second question was how expensive was it? And that was the nice thing about doing this study in Medicare is when you do work in Medicare, costs kind of come along free for the ride. And so we did, the second phase of this particular study was to compare the costs for the patients who had restenosis or a repeat procedure over the year of follow-up to those who did not have restenosis or a repeat procedure. And you can see here the difference was almost $20,000. That's how much each time, every patient who had restenosis added about that much money to the healthcare system. Now, some of this was explained by differences in the baseline characteristics between those patients. So if we risk adjusted this number, it dropped by about $1,000 to right around $19,000. And this is the attributable cost of restenosis. This is, again, how much every patient who had restenosis added over the next year of follow-up, the cost for that. But the number the whole reason we did this study was to figure out this next number. And this next number is what I call, is the economic burden of restenosis, which again, very simply, is the cost per episode multiplied by the frequency in that population. Again, those two numbers came from this study, and they come out to right around $2,200 for every angioplasty patient. That was the whole, we did this whole big study to get this one little number that we wanted to know and what does that number mean? That means if we had a perfect drug-eluting stent that had no complications, and that was free, and that completely eliminated restenosis, we would save the healthcare system $2,200 every time we used it. That's really what this number means. However, even today, 20 years after almost 20 years after the introduction of drug-eluting stents, we don't have any of those things. So our drug-eluting stents are not free. They still cost more than our bare metal stents, about $600 more. We use about 1.8 per procedure, not just one. And they actually, if you really look at the data, especially the data without angiographic follow-up, they aren't perfect. They reduce restenosis by somewhere around 50 to 60%, and then they require dual antiplatelet therapy, which is more expensive. Even with generic clopidogrel, there still is an expense there. And with the newer agents, they're still quite costly. And so if you actually sort of do this math and you work this out in the back of the envelope, even today, even with the prices of drug-eluting stents being much, much lower when they were first introduced, we are still not quite saving the healthcare system money with drug-eluting stents. But it's, but this is, kind of a vanishingly small issue. But again, I just point this out to show, kind of how you can put all of this information together to try to understand technologies, because when they first came out, believe me, they were much more expensive. So drug-eluting stents don't save money. Even today, they don't save money. But remember, when I first started out, I made this 4-quadrant diagram. And I said that most of our advances are up here, and that's true for interventional cardiology as well. When stents first came up, they were in this upper right-hand quadrant where they added costs and added benefit. Embolic protection for vein grafts up here. Intravascular ultrasound up here. 2B3 inhibitors. Almost everything that we do commonly in the Cath lab today, and we'll talk about where TAVR fits in in a little bit, but believe me, that's, that generally is up here as well. So most things are in this upper right-hand quadrant. Every once in a while, I've come across a technology or a treatment that is in this lower right-hand quadrant, what we call economically dominant, where it saves money and saves lives. The one of the best known is primary angioplasty. Primary angioplasty is kind of the no-brainer of interventional cardiology. It's a great tool, and it saves the healthcare system money. And then every once in a while, something comes along that is completely ludicrous. And this was the example from earlier in my career when we were doing laser myocardial revascularization, catheter-based, and we did a placebo-controlled trial, and we saw it was no better than a sham procedure, and it cost money and had a lot of complications associated with it, and that's why we don't do it anymore today, because it was a bad idea on every single front. But for drug-eluting stents are in this upper right-hand quadrant. So now we need to think about the denominator of the cost-effectiveness ratio. We need to think about whether they save lives, or whether they improve quality of life, or whether there's some other benefit that we can't quite think of. So do drug-eluting stents save lives? Spencer knows the answer to this. No, they don't. This is data from, again, in the early days of drug-eluting stents, pooled data from all the sirolimus-eluting stents compared to bare metal stents, 5-year follow-up. You can barely fit the laser pointer between these two curves. No evidence there. If you prefer your data in meta-analyses, here's a meta-analysis of all the early sirolimus-eluting versus bare metal stent trials, and here's the pooled point estimate, which is pretty much right on the unity line. If you like single, big, large randomized trials, well, this is the Nord stent trial published a couple of years ago in the New England Journal of Medicine, 10,000 patients randomized to drug-eluting versus bare metal stents, no difference whatsoever in mortality. So there is zero evidence of drug-eluting stents really saving lives. The reason for this, again, Spencer led this study many years ago as to why this is. It's because restenosis, which is the disease that drug-eluting stents prevent, doesn't kill people. Maybe every once in a while, very, very rarely. Left main, last remaining conduit, something like that, restenosis could kill you. But for the vast majority of patients, it's a relatively benign event that presents gradually or perhaps with a very small non-STEMI. We treat it with another repeat procedure or a bypass operation if it's truly refractory. And so it's not surprising that drug-eluting stents save lives. So we can kind of take that off the table. But they do improve quality of life. And this is a study that we did again about 15, 20 years ago with Stefan Renfred, who was my fellow at the time. And this was actually in the Stent PAMI trial. And what we did there was we collected quality of life data at multiple time points in patients who were undergoing a PCI in the STEMI setting. And then we looked at it. And what we're looking at here are a variety of different quality of life measures assessed at, in this case, at 6-month follow-up. And we're comparing here not patients treated with drug-eluting versus bare metal stents. What we're actually comparing are the patients who had restenosis or target vessel revascularization versus those who did not. And what you can see, whether we're looking at angina, we're looking at a generic measure of bodily pain or energy level or the ability to do your activities, those patients who had restenosis suffered. You know, not forever and ever and ever, but for a period of time, they had significantly worse health status than their compatriots who did not have restenosis. And these were both statistically and clinically significant differences. So there is a benefit of drug-eluting stents, but it's not in saving lives. And so now we have kind of enough information to ask the question, are drug-eluting stents cost-effective, and if so, for which patients? Now, I mentioned before that our standard metric that we use for cost-effectiveness analysis is this cost per quality-adjusted year of life gained. The nice thing about it is we can compare across different diseases. You can talk about this for hypertension treatment, for treating a stroke, for hip replacement, and for drug-eluting stents. And there's a threshold of about $50,000, which is well accepted. It originally started with dialysis. Now it comes from these World Health Organization thresholds. And that's all very, very nice. But what we really would like to think about if we're talking about drug-eluting stents, just as an example, is a much kind of simpler and perhaps more intuitive metric, which is the idea of cost per repeat revascularization avoided. Because this is something that's easy for us to measure in our trials and our observational studies. It actually is interpretable to patients and clinicians. You can kind of get your arms around what it means. The challenge in using this is not measuring it. It's actually figuring out what is the right threshold, what's the right amount that we would want to spend in the United States. And several lines of reasoning have led us to think that it's around $10,000 per repeat revascularization avoided is the right threshold in terms of cost per repeat revascularization avoided. And where does that threshold come from? Well, it comes from the first 10 years of my research career, where we looked at a lot of other things that were not quite as good as drug-eluting stents at reducing restenosis, but we were actually able to measure these cost-effectiveness ratios for all these different things. Things like brachytherapy or stenting for AMI or elective stenting compared to balloon angioplasty, and directional atherectomy, a treatment that's no longer used but was an interesting thing in the sort of the mid-1990s. And for each of these, we were actually able to measure a cost-effectiveness ratio in terms of cost per repeat revascularization avoided. And I have shaded in yellow some of them and one in white. And the reason these ones are shaded in yellow are these are all things that Medicare in the United States decided to pay for. They thought this was beneficial enough and enough of an improvement in health that we will pay additional money for these different treatments, whereas this one down here, directional atherectomy, never was paid any additional amount of money by Medicare. And by sort of looking at this information, we can reason out that the approximate U.S. spending threshold is somewhere between this $10,000 and this $22,000, somewhere in that range, is about what we seem to be willing to pay in the United States. And now we've got enough information to take kind of all the data about drug-eluting stents and put it into one equation. And that's what I've done here. So this is a model. It's a computer simulation model of angioplasty in the Medicare system in the United States that I started doing in the early 2000s when drug-eluting stents first came out, looking at it from a U.S. healthcare system perspective. And this is our analysis that we did in 2003, where we were kind of optimistic about how much drug-eluting stents reduced restenosis. Drug-eluting stents back then were very expensive. They cost about $2,000 per stent, more than the bare metal stents. And we used a little less than we use today, about 1.4 stents per patient. And then we kind of put it all in the computer and let this model run. And what it produces is a fairly simple curve, which is the relationship between the underlying target vessel revascularization or clinical restenosis rate with a bare stent, and the cost-effectiveness ratio in terms of cost per repeat revascularization avoided. And you can see, obviously, it makes sense that as target vessel revascularization or clinical restenosis becomes more common, drug-eluting stents become more cost-effective because there's more episodes to prevent. You can see if you wanted to save money, you'd have to be treating patients who had a expected restenosis rate of around 25%. But if we think about that sort of $10,000 per repeat revascularization avoided threshold right here, what this analysis was telling us is that in 2003, drug-eluting stents were reasonably cost-effective as long as you were treating patients where the expected clinical restenosis rate was 14% or greater. So that's 15 years ago. Where have we come in 15 years? We've come a long way. So again, the cost difference per stent, 2003 versus 2019, has dropped from about $2,000 per stent down to around $600 per stent. We're using a little more stents per procedure. The drug-eluting stent duration has come up, although now maybe it's starting to come back down of the DAPT. And our assumption about what the benefit of drug-eluting stents is early, again, we did all our trials with angiographic follow-up, and we thought it was about 75%. More recently, as we started to do trials without angiographic follow-up, it's probably closer to about 60%. So what happens if we take this new information and we simply update the previous model with more up-to-date costs? So here is the 2003 curve that I just showed you, and here's the curve in 2019. And what you can see is it's shifted to the left, and that means that drug-eluting stents have become a lot more cost-effective. But you can also see that it's not absolutely cost-saving. And if we apply that same $10,000 threshold, here's where it was in 2003. And now if we move it to where we are in 2019, what you can see now is that drug-eluting stents are reasonably cost-effective for a much larger segment of our PCI population, probably for everybody who has a bare stent restenosis rate of more than about 9%. Now, what does that mean? How do we actually translate that into to information we can use or at least think about in terms of determining healthcare policies or how we want to treat our patients? Well, to do that, we need to know one more thing. And again, I'm fortunate to have worked with a lot of good colleagues over the years. This is work from Kaylin Ho and Don Cutlip, who were my colleagues at the BI for many, many years, in about 7,000 patients treated in bare metal stent trials, looking at the relationship between kind of the three main factors that we know that predict restenosis in patients undergoing PCI with bare metal stents: the diameter of the blood vessel, the length of the lesion, and whether the patient has diabetes or not. And you can see that across the range of lesion lengths, vessel sizes, and diabetes, there's really about a 10-fold difference in the clinical restenosis rate if you go from the most favorable group to the least favorable group. And what we can do now is we can actually take that cost effectiveness curve that I built and superimpose it on this clinical outcome curve. And so now what I've done here is shaded in green all of those types of patients and lesions where we would predict that drug-eluting stents in 2019 saved the healthcare system money. And you can see that for the diabetic patients, about half of the patients are predicted to be in that range. For the non-diabetic patients, it's a little bit smaller. But remember, that's not the goal. We're not doing this to save money. We're doing this to improve health. And so now if we add in yellow all those additional groups of patients where our cost effectiveness ratio is less than $10,000 per repeat revascularization avoided, what we can see here is now we've got pretty much the whole diabetic spectrum covered. Everybody except for patients with a 4O vessel and a 10-millimeter lesion, which in diabetics really doesn't exist for the most part. But in the non-diabetic patients, there still is a sliver, not a huge population, but there are still our patients whose outcomes are simply so good that even with the best drug-eluting stents that we have today and our techniques and everything else, we really are not, we may be improving outcomes, but the outcome improvement is so marginal that it probably is not worth that additional cost. And that's the information that we can learn from really applying clinical data, from trials and from registries, economic data from Medicare, and putting them all together in one of these cost-effectiveness models to really understand where is their value, where is their not value. Now, this is all simulation. This runs on my computer. It's a bunch of electrons running around. Do we have any data this is actually the case? And we do. Fortunately, in the early 2000s, Cordis, when they started doing their first trials with drug-eluting stents, were wise enough to come to me and say, let's design a really good cost-effectiveness study alongside of our trial. So this is the Sirius trial, which was the first drug-eluting stent trial done in the United States. And we collected follow-up costs for all the patients in that trial from baseline all the way out to a year. And this is what we saw. This is the follow-up costs in the trial. So for the first 3 months, nothing happened. Everything was exactly the same. But by 6-month follow-up, there were about $1,100 per patient of cost offsets. By 9 months, it was up to almost $2,000 per patient. And 12 months at the end of the primary endpoint of the trial, it was about a $2,500 per patient cost to offset with drug-eluting stents in these relatively complex lesions that were in that trial. So now, again, putting this back together with the original cost data, so that was savings of about $2,500, but the initial procedures were about $2,800 more because of the cost of the stents. And so at the end of the year of follow-up in the SIRIUS trial, we were spending about $300 per patient more with drug-eluting stents than with the bare metal stents. But if we put that into a cost-effectiveness framework, it looked very, very reasonable. It was about $1,600 per repeat revascularization avoided for this technology and for this particular patient population. And if we use some external data to translate into quality-adjusted life years, it was about $27,000 per quality-adjusted year of life gain. So overall, not saving money with drug-eluting stents, not then, probably not now still, but very reasonable value for the dollar. So that's the drug-eluting stent story. I've got many other pieces to that, but I just wanted to kind of lay that out because I think it really just shows you how you can use all this information and put it together in a way to hopefully develop rational healthcare policy. Now I want to switch gears to something which is more relevant today, which is transcatheter aortic valve replacement. You guys have been and continue to be at the forefront of transcatheter aortic valve replacement, and so I think this is, and this one has really occupied probably the last decade of my life. Now I'm starting to sort of turn gears onto the mitral side because we've got most of this pretty well worked out, but I want to share this with you for the last 15 minutes or so. So TAVR, everybody knows TAVR, originally developed for, the extreme risk inoperable patients, has now extended to the high risk and then the intermediate risk, and now in the last year, all the way down to the low risk patients. And there still are, questions about some issues in it, but obviously this has been a revolutionary technology, one that we've all been very excited to be, a part of. Now, before I start talking about the economic work we do, I just want to talk a little bit about something clinical. So I've been involved in TAVR almost as long as the folks here. We started doing TAVR in 2008 as part of the partner trial. And so this is just an anecdote. I just want to spend a minute. So when we started doing this in 2008, we were very excited to be able to offer TAVR to people in Kansas City. And we went to the newspaper and we told them, we're going to be doing our first case. It was September of 2008. This is this really revolutionary technology, less invasive way of replacing the aortic valve. You're going to want to, do a nice story on it. And they said, yeah, that sounds very exciting. We will come, we'll interview the patient. We'll put take some photos of it, and we'll do a nice story. We were very, very excited to hear that. Now, I assumed when you do this sort of thing, that the photo that you take, you kind of stage it, right? You put one of your med students under the drape, and everybody stands there, happily smiling, doing all the nice things, and I assumed that's what we would do the day before when we were just getting trained. But they said, no, we're a newspaper. This is not the fake news. This is the real news. So we need to take a real picture of the procedure. And we said, oh, okay, all right. We'll get our HIPAA permission from the patient and all those sort of things. And they come in and they set up to take the picture. And what I'm going to show you right now is the picture that they ran on the front page of the Kansas City Star, our main newspaper in town, above the fold on the day after our very first TAVR procedure ever done in Kansas City, Missouri. And it was this. So this is the photo. And I cannot tell you how many people, came up to me afterwards, and I said, they thought you said this was less invasive. It turns out, so this lady was 87 years old, steroid dependent, 4'10", 90 pounds, and her femoral artery just unzipped like anything I've never seen before. And we spent the whole, case putting her femoral artery back together. And I also have a bad habit of wiping my hands on the front of my chest. So that's the explanation. But I actually really like this photo. It's actually, we have a display case at MAHI that shows this. And the reason why I really like this photo, other than to get some giggles out of everybody in grand rounds, is because it actually shows the whole heart team, which I thought is kind of unique. I don't know that they knew they were doing this when they took it, but here's my partner Aaron Grantham. Here's me. Here's Trip Zorn, our cardiac surgeon. Michelle Haynes, our cardiac anesthesiologist, and this is Mike Main's hand running the TEE. So we have the entire heart team is in the photo, and I think that again has been one of the real take-home messages from TAVR. But I say that just to sort of make sure that that I still can do these procedures on occasion, and we generally do them a little cleaner than this today. But when TAVR started, we knew this was going to be a big issue for the economics, and it has been. Again, here's an editorial written in the British Medical Journal a few years, about 4 years after that picture was taken, saying this is a risky and costly procedure, and there have been, and there still are very many concerns about the cost of TAVR because of the cost of the valve. And so, again, we went to to Edwards when they were designing the study and said, you're going to need to know about this. I mean, this is not going to be a trivial matter. There are so many patients who could be affected. We need to study this very rigorously. And again, we were very lucky that they allowed us to design a really excellent health economic study in conjunction with the very first TAVR trials. And this is the first one. So remember, this is the TAVR, the Partner 1B trial. This is the trial for the extreme risk patients who were inoperable. So we wanted to understand and there were a lot of questions about that group because this is a group of patients who, were really being neglected by the healthcare system. Is it going to be cost effective to take these 83, 84, 85-year-olds with multiple conditions and fix their aortic valve? So the first thing we had to do was figure out how expensive it was to do TAVR. And in that day, it was a little different than it is today in terms of the length of stays. These were the sickest of the sick. Some of these patients nowadays, you would say, you might not even consider to treat. So we started out by just saying, how expensive was it? And the answer was expensive. It cost, from going in the door of the hospital to getting out the door of the hospital for just the initial treatment, cost $78,000. About $42,000 of that was the procedure. The vast majority of that was the valve, obviously, which costs about $32,000 still in the United States. Another $30,000 of that was the care in the hospital beyond the initial procedure, the length of stay in the ICU and in the hospital. And again, it was much longer those days than it is today. It was about a 10-day length of stay for these very sick patients. It was cut downs and complications, all those sort of things. About $5,000 worth of physician costs. So we have really about $78,000 worth of costs. That's kind of the bad news for TAVR. The good news was over the next 12 months, it really saved the healthcare system a lot of money. So we followed up all their hospitalizations, all their rehab care, all those sort of things. The vast majority of where those savings came from were hospitalizations, where we saved about $26,000 per patient. But when we added that all together with the initial $78,000, we came up with the total 12-month cost. It didn't save money, just like drug-eluting stents. In fact, it still added about $50,000 worth of cost for TAVR because of the upfront cost. Even though, again, it reduced rehospitalizations and all those sorts of things, it didn't save money in the long run. So again, we're back in this realm where we have to think about what is the benefit of drug-eluting stents. And in contrast, of TAVR, and in contrast to drug-eluting stents, now we have survival benefit. A very clear survival benefit in the trial. And when we started to do this health economic analysis, this is the data we had. We had 1 year data on everybody. We had extended follow-up data out to about 30 months on the earliest patients in the trial. And if you look at these two survival curves and you add up this area in orange in between them, the gain in life expectancy that we observed during the trial was right about a half a year of life. But of course, the trial didn't end and the patients didn't all die at month number 30. These patients have continued life expectancy beyond this. And so in order to really estimate what are the true benefits of TAVR for this population, we have to project those curves. We have to, again, do some fancy math, some regression modeling, and some survival curves. And so this is, again, just another representation of those same data. And we fit curves to those, and then we extended them, and they look something like this. And then we're actually able to add up the area between those. And it actually turned out, in retrospect, we did a pretty good job. So eventually the trial had 5-year follow-up data, and here's the 5-year follow-up data that were observed compared to our projections, and we were pretty pleased with that. We got them pretty close. But if you add up the area between these two curves, now it's not 0.5 of a year, it's actually almost 1.8 years because of a lot longer life expectancy for some of these patients. So that is the gain in life years, and we can quality adjust those because we measured quality of life. And so when we put that all together, here we are back in that cost effectiveness plane that we talked about before. And here's where the data from the Partner B trial are. Every one of these little dots is a simulation of the trial. We do a technique called bootstrapping where we mathematically resample and rerun the trial. This is 500 samples. We did it 1,000. We did it 10,000 times. And they're all in this relatively tight cluster up here in the right-hand quadrant. So there's a couple things we can tell from that. First of all, we can tell that TAVR is saving lives. It is to the right of the benefit line. So we are adding, lives, or in this case, quality adjusted, years of life. But it's also expensive. It's not saving money. It's all in this upper right-hand quadrant. And if we look at this sort of central estimate, the means of both of these. The net cost over a patient's lifetime is about $80,000, and the gain in life expectancy was about 1.6 years. And if you just do the simple math on that, you get $50,212 per life year gained. It's, almost too conveniently right at the cost effectiveness threshold that we talked about before, but this actually is where the math came out. This green line then is a $50,000 per life year gain threshold, and you can see that it bisects that distribution. So we're about 50% confident that it is, highly cost effective below this threshold, and we were absolutely confident that it's below a $100,000 per year of life gain threshold. And so we can at least get some reasonable bounds on this cost effectiveness and conclude that it's somewhere between high value and intermediate value, even for these sickest of the sick patients in the U.S. healthcare system. Now, one of the interesting things about this, this analysis, this is kind of where I would have guessed it would have come out. But I remember talking to the folks from Edwards when we first started this study, and they said this is going to be the no-brainer of all time, because we're going to prevent so many hospitalizations for these patients. We're going to keep them out of nursing homes. We're going to do all these things. We're going to save lives, and we're going to save money. And it turned out that was not the case whatsoever. And this gives us the opportunity to really ask, why is it that TAVR, which is a really remarkable transformative technology, doesn't save money for these patients? And there really are two reasons. Why doesn't it save money? Number one is the control patients who got medical therapy die too quickly. They're very expensive, but they die, half of them are dead in a year, so they actually don't contribute that much cost. And then probably even more importantly is we recognized from these data that we collected that the TAVR patients, even after their TAVR, are very expensive to keep alive. And it turns out that because of this issue, because these patients, you cured their aortic stenosis, yes, but they still have all the things that made them extreme risk. You didn't treat any of those. You didn't fix any of those. And those mean these patients, every year of life adds about $30,000 to their care. And it turns out that even if the TAVR valve was free, $0 for a TAVR valve, you still wouldn't save money with TAVR because of these two basic principles, at least compared with medical therapy. So now, again, we've started this path, and the next logical question is, okay, you've shown us, a population and a trial where it is reasonably cost effective, but when isn't it? There must be cases wherein it isn't. And we can use the same information in a modeling framework to try to address some of these questions, which I think are some of the most interesting ones. So when is TAVR not cost effective? Well, it turns out TAVR is not cost effective if the patients who've had a TAVR don't live long enough to get really the benefit. And it turns out that where that threshold is probably about a 3-year life expectancy. And that comes from a graph that looks like this. So this is the relationship between the life expectancy after TAVR and the cost per year of life gained. And again, you can see if you're willing to spend $50,000 per year of life gained, then right around you need 3 years life expectancy, which is exactly what we saw in the Partner B trial. That's why the threshold was right around $50,000 per year of life gain. If you're willing to spend $100,000 per year of life gain, well, they can live about, you can have a shorter life expectancy, about 2 years. But that's a very important piece of information. This is, information that we can use as clinicians and as policymakers to say, who should we really not treat? If somebody's got terminal cancer, it doesn't make a lot of sense to do a TAVR in them. If they're only going to be living for 6 months or, a year, it's going to, yes, they're going to feel better, but it's going to be for a very short period of time. It may not be a very wise investment of our healthcare dollars. A second place where TAVR is not cost effective is if quality of life doesn't improve. And how do we know this? Well, we can know this by taking this yellow plot, which is the data that I just showed you from the Partner B trial, and then taking away the quality of life benefit mathematically, just saying, what if the patients lived longer but they never felt better? And what happens then is you take this whole cloud and you shift it to the left. It becomes less cost effective. And in fact, now the cost effectiveness ratio is not $50,000 per quality adjusted year of life gain. It's more like $90,000 per quality adjusted year of life gain, and it's getting closer to the margin. So that's another thing, and certainly all of us who do this procedure, when we're in the heart team thinking about these, we try to think about whether this is going to help the patient, whether they are going to feel better. And then the last one that I really want to highlight is a different comparison that we've been interested in more and more recently, which is another place where TAVR is not going to be cost effective is if surgical AVR is equally effective but less costly. And to go to that, we have to actually start going to intermediate risk. So this is data that we published with my colleague Suzanne Barron, published earlier this year in Circulation from the intermediate risk partner trial, from Partner 2A. So that was an 2,000 patient intermediate risk trial comparing TAVR with a second-generation device, the Sapien XT valve, compared to surgical AVR. And again, for this study, we were able to do for the first time what I've always wanted to do in a cost-effectiveness analysis, and it really was a kind of perfect storm of timing and the kind of patients we treated. We were actually able to take the trial data and link them up with Medicare data for all these patients. So we actually were able to follow all of their expenses from Medicare. We were able to link about 80% of the patients in the trial to their Medicare data, and then we could follow them forever and ever and ever, both for mortality as well as for their costs. So this is the 2-year data that I'm going to show you. So this is the index hospitalization cost, the procedures. Again, TAVR is much more expensive than surgical AVR by about $22,000, but you get almost all that back just before they even leave the hospital because of the shorter length of stay that's associated with TAVR. And again, this is second generation, still not probably everything that we are doing today. Here's the physician piece. And so at the end of the hospital stay in the PARTNER 2A trial, TAVR was still more expensive, but it wasn't $30,000 more expensive. It wasn't even $22,000 more expensive. It was only about $3,000 more expensive by the time the patients left the hospital. But the real TAVR story is here, which is the follow-up costs over the next 2 years. And this was really remarkable to see this, because compared to surgery, over the next 30 days, we saw almost $4,000 worth of less costs from Medicare. Over between 30 days and 6 months, another $7,000 worth of fewer costs. And this is really driven by two things, which is reductions in rehab, which turns out to be very expensive, and reductions in rehospitalizations, especially for the surgical patients. That drove a big part of these cost savings. By the time you get out to 6 to 12 months, the cost savings kind of are almost done. 12 to 24 months, basically neutral on the cost. And so if you add all these follow-up costs together over 2 years, there's about $9,000 worth of offsets compared to surgery over those first 2 years. And if you put this all back together, obviously there were $2,000 to $3,000 more in the hospital. This is the first time we ever saw TAVR saving money, okay? We're now not in that upper right-hand quadrant. We're in we're in the lower right-hand quadrant where we're saving money and improving outcomes for our patients. And in fact, here is the total 2-year cost, about $6,000 lower for the patients. But remember PARTNER 2A, those of you who were part of it or remember it, it really was 2 trials in 1, because the patients were stratified at the time they came into the trial by the access site. 3/4 of the patients were treated transfemorally, which we know is the best outcomes. But 1/4 of the patients were treated through the chest, either transapical or direct aortic. And that's where this idea of where we can really make a distinction comes from. So here is the cost effectiveness analysis in the 77% of patients who had transfemoral access over a lifetime perspective. And you can see, like I said, that we're basically in this lower right-hand quadrant where all technologies would like to be, where we are saving money and we're improving health. We're saving, actually, for these transfemorally treated patients, $11,000 per patient over their lifetime and gaining about 0.3 of a quality-adjusted life years, which is actually a pretty reasonable amount. But what about the other 23% of patients? What about the patients who could not have transfemoral access? The patients who had transthoracic access are the exact opposite. These patients are mostly in this upper left-hand quadrant where we have worse outcomes and higher costs, and virtually all of our simulations are above this $50,000 per quality-adjusted year of life threshold, so not cost-effective whatsoever. Again, a net positive cost of about $4,000 and a loss of quality-adjusted life years. And so if you were trying to decide, when should you do TAVR and when should you do SAVR, well, the access site is a pretty good idea of where you should do it. If you can do transfemoral access, go wild. If transthoracic is what you need to be doing, this really tells us that we probably should rethink that. We shouldn't be doing transthoracic access. And again, fortunately, TAVR has evolved to where the vast majority of our alternative access TAVR is not being done by a technique that is as crude as transthoracic access. So let me just finish up with a couple of take-home messages, and I'll be happy to take any questions. So kind of a whirlwind tour around health economics. There's 4 points I'd like for you to kind of go home with. So first of all, cost-effectiveness analysis is not about saving money. What it actually is about saving lives, but recognizing we don't have an infinite amount of money to do that with. Secondly, treatments are not cost-effective unless they're effective. Remember, the denominator of the cost-effectiveness ratio is effectiveness, so if that has to be greater than 0 in order for a treatment to be beneficial. And again, I think this is a very important message, is if you want to be cost-effective, the first thing you have to define is the effectiveness of the care. Third, hopefully these couple of examples from drug-eluting stents and from TAVR have shown you that, again, with both applying clinical reasoning, clinical data sets, as well as economic analysis principles, we can use these types of analyses really to supplement our mechanistic and our outcome studies to help develop evidence-based guidelines, true evidence, for device utilization and treatment strategies that ought to really come into practice in our healthcare policies, reimbursement decisions, and those sorts of things. And then finally, for those of you who are just kind of starting your careers or early on in your career, I think it's not a depressing story at all. Technologies that increase the overall cost of medical care, may be acceptable in the future, but that's only going to be the case if we can demonstrate improved clinical outcomes that are meaningful to our patients, and that basically is improving their life expectancy, reducing their symptoms, or improving the quality of life, and really brings, kind of full circle that, what we're talking about with cost effectiveness really is just another way of measuring effectiveness and applying some quantitative principles to it. And hopefully, all of you who are involved in biomedical research for the next, several decades can kind of keep this in mind and make sure we gather the right kind of data from our trials to ensure that we can define the value of the technologies. Thank you very much.
David, that was fantastic. I'll start off with one sort of comment and question. So in a few weeks, I'm going to go up and do study section for SBIRs and STTRs. And all those biotech companies that were knocking at your door will be there trying to validate. And one of the things they hear is, well, if it's not cheaper and better, we don't want to fund it. And so the concern is that this sort of mutation of cost effectiveness can squelch creativity. And I was wondering, sort of, relative to your last point, how do people think about that at early stage?
So that's a great question, Bob, and it's one that I've wrestled with for a long time. And I think you're onto something. You're not off base there. Is we have to watch out when we do this that we don't do it prematurely, because I think if this is really an approach that should be evaluating relatively stable technologies, things that have developed and figured out what they're, how to use them, who to use them in, all those sort of questions that you need to figure out when you're developing any kind of new technology. And it is a bit risky, frankly, it's quite, risky if you apply these techniques too early, because, most technologies, you don't know where they're really going to end up. And so I think there is a balance, just like a balance when you're running clinical trials. When we're running a clinical trial for a new device or a new procedure or anything like that, we have this balance between we want to do it early before it's widely adopted so we can get a good representative population, kind of how TAVR was done. But if we do it too early, we may not know how to do the thing right, and we could, again, squelch very good technology. It really, to me, is one of the miracles of TAVR is that TAVR turned out to be such a good technology that even when we didn't know how to do it, back in 2008 when my chest was all full of blood, it still looked pretty good. There aren't that many technologies that can pass that hurdle. That's a real, an incredible winner to be able to pass that. So I think it is something that has to be kept in mind, is not to do this kind of work too early, or you'll, again, you might throw the baby out with the bathwater and miss the whole thing. So I think a great point. So don't take this stuff too much to heart when you go up to study section for that stuff.
Any questions?
Habib.
David, that was fantastic, and I've really enjoyed and learned from you over the years, and really you've led the thought process on a lot of these important issues. And actually the two case examples you showed really bring to life some of the lessons you taught us at the beginning. So just a question about each of those case examples. Mm-hmm. With regard to the coronary world, the bare metal stent use is almost negligible now, and I think you make the case very well for that, and particularly as the DAP therapy now shortens even further. So that, I assume that at least the economic sort of argument for using bare metal stents is pretty much gone.
It's pretty much gone. There are, there's very rare cases. You've got a, discrete 4.0, mid-right coronary with a 5 millimeter long lesion. The amount you're going to gain with a drug-eluting stent there, you're going to gain, but it's going to be this infinitesimal amount. That's probably a waste, but it's not a waste to the patient, right? The patient's still going to have a better outcome. It's just, you're spending a little bit more money than we, really think is a wise investment. But that's, we have come that way over a long period of time. It's been, we've had drug-eluting stents now for 16 years in the United States, and it's taken us, most of that time to get to where we are today.
Yeah, so, and I guess great. So my second question is, I think TAVR is evolved, and the work that Adam and Vasilis and others have done with transcaval hopefully will bring that,
That-
non-transfemoral
those 23%,
axis down to the right. But the real big question in front of us now is this sort of shock group of patients, right? Patients that arrive late in their disease process, they have shock, and there's a lot of thought about who to dispense, these expensive dollars on, whether it's, percutaneous pumps or ECMO. And how far do you think we are in that clinical process to start making an economic analysis? Because I know that a lot of the big hospital systems are struggling with that.
Well, I mean, fortunately, on the hospital, again, remember, this all comes down to a little bit of the perspective. In the hospital perspective, my understanding is the hospitals are still pretty happy when you throw in an Impella or something like that because they get, a good payment for it. But, Medicare is the ones who should be concerned about that because we're probably overusing those technologies, because we don't have good evidence as to when, where they work. And it does, it points out, I've been very lucky, these two examples that I showed you are areas where we have done a wealth of clinical trials, and we really have great clinical evidence on which to sort of frame the economics. In the area of, cardiac support, especially Impella, tandem heart and those sort of things, we have none. I mean, we really have none, and it's a big problem for our whole field is we don't know if they're any good, and I'm not sure we're ever going to know it. And that's this issue that really comes back to this issue that Bob was raising is sort of, unfortunately for studying those, kind of the horses out of the barn because it's hard to undo. The last decade worth of practice and all those sort of things to get the clinical trial data that we need in order to understand what the benefit is. And again, that's why we were so lucky in some ways with drug-eluting stents where, they were only available in the trials, so we got to study them in really good randomized trials, double-blind, trials, in fact. And with TAVR, because it wasn't, being reimbursed, and the only way to get a TAVR in 2008 was to participate in those trials. And so those, and that's, if you want to really get the kind of evidence you need, both build the clinical guidelines as well as the economic guidelines, you need to do these trials relatively early before these things are completely into our practice. The challenge for that, as I just said, is that sometimes you don't know how to use the thing, right? I go back way back. Spencer will remember this. We had this technique called directional atherectomy that came out in the early 1990s. And we thought it was going to reduce restenosis. And and you probably remember this as well. There was the first trial that was done with directional atherectomy that Eric Topol led, the Caveat trial, showed no benefit whatsoever compared to balloon angioplasty back then. And then Don Boehm and Marty Leon and a couple of other people, Chuck Simonton, said, but they really didn't do directional atherectomy the way it's meant to be done. They didn't take much plaque out. They didn't post-dilate the lesion. They just were working on the assumption that if you threw this atherectomy device down the artery, shaved a couple of little, millimeters of plaque out and took it out, that it was going to reduce restenosis. Let's do the trial again with, the best techniques that we have. That was the BOAT trial that was done a couple of years later, which showed that, in fact, it did reduce, restenosis when it was used appropriately. And so we have to, we really, in the device field, in the procedural field, we have to run this very careful balance between testing our technologies too early when it's easy to do the test because they're not in practice, or testing them, too late when we know how to use them very well, but they're already, well adopted, like kind of with the case with Impella. So it's a long answer around. I don't know if we're ever going to get the answer for Impella because again, we've just started this. We're too late to it. I'm hoping, my own personal hope is that the folks in the UK who have very little access to things like Impella will they're great trialists over there. Why can't they do the trial for us and answer the question? I hope they can. Yes, come here. Way back. Got to get him a mic.
So I think, to Habib's comments, I think staging shock.
Keep them short, we're a little over, okay?
Sorry?
Keep them short, because we're a little over time.
Okay.
I'll make my answer real short.
I'll change this topic. So,
Okay.
in the same pot of money known as Medicare, you have somebody that's with 65 years of age and gets $50,000 of chemotherapy for pancreatic cancer and gains 6 months. And you have a high-risk TAVR who gains all 6 months, and the pot is Medicare. When will society say, or Medicare say, enough is enough, screen them better, and your QALY is not appropriate for this?
That's every question you guys ask is one that takes a 5-minute answer. I'll give you the simple answer is, I hope soon, because among the reasons why we have a healthcare financing problem in the United States today is because we are, at some level, we're uncomfortable talking about costs. We really don't want to, make decisions based on these things. Other countries, the UK, Netherlands, other developed countries that have good healthcare systems have wrestled with this, and they've said, here's our threshold, and we're just not going to pay for things that don't meet a reasonable, cost-effectiveness threshold. And I think until we get there in the United States, it's really a political question, a societal, question. It's not a math question. It's not a clinical trials question. It's not a, outcomes question. It's whether we as a society are willing to, to explicitly use the R word, ration care, or whether we're going to continue to do it, implicitly and kind of below the table, which is how we do it now. We make these decisions, but they're not out in the open. So I personally think it's better always to be transparent. It's better always to be upfront about what you're doing, and I would like to see more of this kind of information be integrated into our decision process and into our, into our reimbursement policy. But right now in the United States, we're not quite there yet, but I think, every year we get closer. So, I hope.
I think in the interest of time, we're going to go ahead and stop. Like with all great talks, we have more questions than we have time for. But thanks so much for coming down, and thanks for a great talk.
Well, thank you
That
very
was
much
fantastic.
for coming.
The preceding program is copyrighted by Emory University.